Well, welcome and thank you for joining me today for episode number 11 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. If you do like what you hear today or what you've heard in previous episodes, please do tell your friends and family and colleagues about this podcast. It really goes a long way in helping to get the podcast out there. So today I'm going to talk about the topic of medical errors. Medical errors are, believe it or not, estimated to be the third leading cause of death United States, leading to an estimated 250,000 to 440,000 deaths each year. According to one recent survey, we healthcare professionals are quite aware of the risks of a healthcare system, but patients may not be. So my guests today are going to give some very practical tips that you can use for yourself or your family to keep yourself safe and protected from the healthcare system. My first guest is Miss Linda Beck. She's the founder and principal of an excellent organization. It's called Square One Elder and Health Advocacy. It's dedicated to helping older patients and their caretakers get the services that they need. You can learn more about Linda and her organization at squareoneadvocacy.com. My second guest is Michael Eisenberg, who is the producer and director of a wonderful film called To Err is Human. It's about medical errors. It can be found on a variety of different media platforms, and they can all be accessed at toerrishumanfilm.com. Toerrishumanfilm.com is where you can find it. Again, if you do like what you hear today, please do search for and subscribe to the Healthy Skeptic MD wherever it is that you listen to podcasts or on YouTube. Okay, so before we get into today's discussion, let's do a rundown of this week's health news. And how could I not but start with a discussion of the exciting new data about the Pfizer COVID-19 vaccine. So the new data comes from an analysis of 43,000 patients, half of whom got 2 doses of the Pfizer vaccine and the other half got 2 doses of a placebo injection. Now, the trial began in July, and since then, a total of 94 study participants have been diagnosed with COVID-19 infections. More than 90% of these 94 individuals were in the group that received the placebo injection, and that's where the statistic that the vaccine is more than 90% efficacious comes from. So this is certainly great news, cause for a celebration and a sigh of relief. It's also a real credit to human ingenuity. It's amazing how much progress has been made and how quickly the vaccine was developed. And it's a very interesting vaccine. It's a new technology that uses genetic material, mRNA, that's administered to people, and it tricks our cells into making virus-like particles that trigger an immune reaction. So very, very exciting on the scientific side. The next step for Pfizer and the regulatory process is to collect a full 2 months worth of safety data. They anticipate that data will be collected by the end of November. After that, they will try to submit what's called an emergency use authorization. This is an informal approval from the FDA to begin to administer the vaccine to certain high priority populations like healthcare workers and other essential workers and certain individuals with high risk conditions. I think it's a great mechanism because it allows the vaccine to be distributed early to high-risk groups, but it also ensures that the FDA has adequate time to continue to monitor the safety data and other data that comes in before granting that full formal FDA approval. Okay, so the next health item I want to talk about this week is vitamin D and COVID-19, and this is certainly a question I've gotten a lot from my patients over the last couple of weeks. So the interest in this comes from the simple fact that it's been observed that many of those with really severe COVID-19 infections tend to have lower vitamin D levels. But it's actually a fairly complex situation. And the reason is, in many ways, vitamin D is actually a marker of good health. The reason for that is the main way we get vitamin D is from sunlight. So those who tend to be healthier and spending more time outdoors and exercising and in the sun tend to have higher vitamin D levels, which may explain why they're less likely to get severe COVID-19 infections. In addition, there hasn't yet been a convincing study to suggest that giving vitamin D supplements leads to less severe or less likely to become infected with COVID-19. And the pills themselves have some downsides. They're big pills to swallow, and if you take too many of them, you can actually get excessive levels, which causes its own set of problems. So what I've been telling my patients on this one is, and particularly this is important now that we're headed into the winter season and there's less sunlight, make sure to get outside, even if it is cold, and do get some sun. Don't overdo it and get a sunburn. But get outside, exercise, be healthy in the fresh air. You can also get some vitamin D from fortified milk and orange juice. Not a lot of foods have vitamin D in it, but supplemented milk and orange juice do. But I don't think it's necessary for all of us to rush out and get tested for vitamin D unless there's a specific reason you or your doctor are worried about a true vitamin D deficiency, which most of us do not actually have. And I certainly don't think we all need to rush out and get vitamin D supplement pills at this time. Okay, so with that, let's jump into our interview for today. Well, Mike and Linda, thank you so much for joining me on the Healthy Skeptic MD today to talk about the important topic of patients advocating for their own safety in the healthcare system. So welcome to the show.
Thank you. Delighted to be here.
Thank you.
Well, you both have very personal reasons for having gotten involved in this topic. And maybe we could just start out by hearing a little bit about that, Linda, if you don't mind, and then Mike telling us a little bit about how you got interested in patient safety.
Sure. The short story is that my mother died of a hospital-acquired infection, and my father, died after a bed sore became gangrenous. And I realized that these were not isolated incidents. This was going on a lot. And the fact that it's still going on after all the efforts to address it, got to do something.
Well, that's great. And what's really great is that you do it on the patient side, because there's a lot of interest in the health profession side, but unless we have patients engaged and involved in this issue, I don't think we're going to get to the bottom of it.
I agree.
And Mike, how about you?
Well, yeah, I started this project called To Err Is Human, a documentary in 2015, really kind of on the heels of this very sort of third-hand experience that I had with patient safety, which was that my father was the director of the Agency for Healthcare Research and Quality, which to many in the patient safety world is a familiar and important agency. But for me, someone who hadn't learned much about it, I was 17 when he passed in 2002. I knew that he had a significant impact on people, but I didn't quite understand fully what it meant. And I became a filmmaker eventually, and what we do is we ask questions and we find out more information about things we're curious about. And it came in 2015 that AHRQ might lose its funding. And that's something I knew was a question every year for that agency. So we went out and we interviewed people who worked with my dad when he was at the agency, as well as people who were running it at the time, and asked, what this means for healthcare, what it means for AHRQ. And patient safety and medical errors kept coming up. And so from this small video we wanted to make about AHRQ, grew this documentary that became a passion project for myself and my two partners, Matt and Kaylee. And at the heart of it all was trying to better understand my father's life work, his legacy, and what he had left behind, and what the people who he impacted the most had been doing for the last 20 years. So that not only could I, as an outsider, quote unquote, learn about patient safety, but what could we help to do as filmmakers to expand the reach of that work so that more people can get involved and be interested in help.
Mike, where did the name To Err Is Human come from?
Well, there's a report that came out in the late 90s called To Err Is Human. It was published by the National Academy of Medicine and made a huge impact at the time on an area of healthcare nobody was really familiar with, and exposed, if you will, this growing problem of preventable harm and medical errors that could be potentially solved. And a lot of people became career patient safety researchers or advocates in their own way. But 20 years later, which was roughly the time we knew the film would release, where is it now? And how far have we come since that initial landmark report? We felt that the film itself was about the fact that humans will make mistakes. And we have to understand what that means in a healthcare setting. And how do we deal with that fact, that reality, and work around it rather than try to make people perfect and expect them to never make mistakes? Rather, how do we design systems around the fact that they will?
Well, as a doctor, I love that because it just highlights that I'm human too, and I shouldn't be expected to be perfect, but we need to come up with systems fixes so that, to help people who are humans and make mistakes, take the best care possible of patients. But let's get to that 2 errors human report. It caught a lot of people's attention in 1999 when it first came out because it showed that medical errors are one of the top 10 leading causes of death in the United States. And despite all the interest following that film, recent estimates have actually placed that number a lot higher. The most recent numbers I've seen are somewhere between 250,000 to 440,000 deaths every year due to medical mistakes. To put that in context, we've had about 225,000 deaths from COVID so far during this pandemic. If these numbers are accurate, which I actually think they're probably an underestimate, it would make medical errors the 3rd leading cause of death behind heart disease and cancer right now. So maybe I'll start with you, Mike, on this one. How are medical errors identified? How do we get these statistics?
Well, I'm glad you brought it up. It brought up a lot during our panel discussions after screenings. The question of how many people die. First of all, we should always address the fact that it doesn't really matter. It doesn't matter if it's 220,000 or 400,000 or 400 million or 4. People are dying in a preventable way. And anybody who's working in this field works to make that number 0, right? People will always die during the course of care. That's understood, but can we prevent the harm that's caused by mistakes? And the numbers have become this very hot point of discussion that oftentimes we then lose track of the things we need to be focusing on. But it is important because people, you turn on the TV, whether it's COVID or it's an election or it's nothing, neither of the two, there's some statistic on screen. People care about numbers. That's how they identify scale. And when we were making the film, we went through the numbers and the research, and we were faced with our own dilemma of what number to use in the film, right? Because we're going to make these animations. We can't really turn back. And once the film's out there, it's out there. And the new numbers come out, they're more accurate, more or less. So there's John James, the study that you referenced that goes up to 440,000 estimated every year. And then a more recent study in 2015 from Johns Hopkins that said it's closer to 225. There's like an exact number. But all of these are estimates. And there's a lot of people out there who, to steal from your title here, who are skeptics of this data. And I think they, as I mentioned in the beginning here, lose track of what's most important, which is each person and each family and each incident. But we're in a time now where as many people have died from COVID, and as you said, likely more, because it's very difficult in healthcare to actually get a number of any kind. Healthcare is complicated. Diagnoses are complicated. Causes of death are complicated. And to finish my comment here, in our film, we focus on the Sheridan family, which maybe we'll get into more later, but Pat Sheridan, Sue's husband, was diagnosed with cancer, and they initially got readings back that it was benign. And they did some follow-up reports or studies, or whatever you call it, and 6 months went by before they pushed back and followed up to get the answers, and they found out that it was actually a malignant tumor, very aggressive malignant tumor, and they lost 6 months of treatment they could have had. Now, he died from cancer, and no one is debating that. It's on the death certificate. It's what ultimately took his life, but we can't forget that that's one of those deaths to medical errors, right? You're not going to put medical error or preventable harm on a death certificate. It's just not how it works in this country, but we have to find a way to be able to identify when someone's life is cut short due to an error that could have been prevented.
I think that's so well said. And I think a lot of times people think, medical error means they operated on the wrong part of the body, or they overdosed the chemotherapy. But so many times it's the simple things. It's the urinary catheter didn't get taken out a week before when it should have. The appointment to the cardiologist just didn't happen because we put so many barriers in the way. The doctors didn't talk to each other and communicate and coordinate the care. Those simple things that spiral and result in a horrific outcome. And I think when you put it all together, I actually think these numbers are probably, sadly, an underestimate of how big the problem is. Linda, from your experience working directly with patients as an advocate, have you ever actually seen one of your clients die or be seriously injured as a result of a medical mistake?
The short answer is yes. It goes back to your point, though, that it's usually not some dramatic incident like a wrong site surgery or an overdose of some kind. It's that cascade of small mistakes that add up to unnecessary harm and, in some cases, death. One of the most dramatic examples I have is a woman who was living independently on her own, despite a variety of disabilities, and she fell, broke a leg, went to the hospital, was discharged to a skilled nursing facility, and number one, she was transferred on a weekend, which is something to avoid. And once they got her settled, one very important piece of information was lost in the transition. She was blind. You couldn't tell it by looking at her, but she couldn't see. And because staff hadn't been informed that she couldn't see, they weren't following the many conventions that go with dealing with a visually impaired person. They weren't telling her, orienting her to where her call bell was or her water was. And long story short, because things weren't placed where she could find them, she wasn't getting enough fluids. The next piece that went with that, you can see where this is going. She spiked a fever one day. The family asked about it. They said, oh, it's gone, nothing to worry about. Next thing you know, this very amiable woman is combative. She's fighting off staff that's trying to help her. Again, the family asks, this is not her. What's going on? Staff says, oh, she's having a bad day. No, she had a urinary tract infection. And those symptoms, the brief fever, the unusual behavior are classic symptoms of a urinary tract infection in an older adult. And because staff didn't identify the problem and deal with it, she developed sepsis and she died.
What's such a classically sad example of what happens, it is so hard to be a patient in the U.S. healthcare system. It's so hard to get appointments when you want it. It's so hard to get your stories communicated. And you add to that a disability like blindness or the fact that you're sick and you're in your least, able state to be able to advocate for yourself. And it's just so easy to see how things like this happen and they just pile up. Now, a lot of my colleagues who are, many of them are very sympathetic to the problem, but they'll just say, medical errors are just part of the healthcare. It's just part of doing business. It's what allows us to give all the good treatments and save the lives, but we do the best we can, but there's always going to be medical mistakes and bad outcomes. And maybe starting with you, Mike, what's your response to that?
I just disagree. There's a difference between the course of care being complex and making a mistake. It's an error for a reason. It wasn't supposed to happen. When I speak about patient safety, I bring up the analogy to baseball because I played baseball for quite some time, and it's one of the only sports that has errors as a statistic, right? And somebody's in a booth determining whether or not that was an error. We know generally what an error looks like in baseball, but sometimes it's a little trickier to determine the underlying factors and sort of look at it, and then you wait for the scoreboard to change, and it's an error or it's not. And somebody's making that decision. It kind of happens in healthcare to an extent, but imagine if, in baseball, for example, it was up to the players to report their own errors. You think they'd do it? You think they wouldn't have an excuse as to why it hit a rock, and that's why, so it's not my fault. But it parallels.
That's a great analogy, and I just say, sometimes I'll look at a patient, and if you look at the full story, it's clear that we did not do a good job and the patient had a bad outcome because of all these things that happened. But we never recognized that. We never sort of, we just sort of pass it off as this is just part of doing business. And, unless there's an objective, independent assessment done, we're never going to see that because like a baseball player, we don't want to see. Yeah. We don't want to see that.
Well, but then the systems where, patient safety or errors are taken seriously, it's an environment of transparency where when something goes wrong, everybody finds out about it. And they even sometimes post things on bulletin boards that patients can see about what happened and how they prevented harm from occurring. So instead of just waiting for something devastating to happen and for you to have to do this sort of on your heels reactionary approach, getting ahead of it, understanding healthcare better than the patients will, so that they're not the ones telling you when something's going wrong. At the same time, as Linda can attest to, the patients are sometimes the most valuable resource on the team, and they're often overlooked and underappreciated.
Two quick things. One is that the baseball analogy is wonderful. I have a background in the construction industry, and that is a very safety-oriented business because it goes directly to the bottom line. And I think that we can learn a lot from how construction companies have approached safety right at the grassroots level. Weekly, what they call toolbox meetings. Before anybody sets site and sets foot on the site or picks up a tool, you get together and you look at and talk about one of the issues that is commonly responsible or commonly leads to injury. And why aren't we doing that sort of thing in healthcare? Mike, in the movie, you interviewed Captain Sullenberger, who was hero of the Hudson, and he made the point, and I don't remember whether it was in the movie or not, that if aviation had the safety record that healthcare does, all flights would be grounded until we solve the problem. And we don't have that option in healthcare. People need healthcare. So what do we do to fix it on the fly? And that's what prompted me to raise this issue with Michael, because the Patient Safety Foundation issued a report earlier this year, talking about, what the statistics are and what we can do about it. But their conclusion was that they have to educate the healthcare providers and the healthcare workers, not the public.
Yeah, so I think you make some excellent points about some of the things the medical profession needs to do better and learn from some of these other industries. And I think you are absolutely right that we need to do it in a way that's non-judgmental and acknowledges that people are people, and that we need to fix the systems and not criticize individuals for making mistakes, which we all do as humans. But what I think is really innovative and creative about the work that both of you have done is that you've tried to do exactly that, Linda, what you said. Look at the other side of the equation. Look at the patient side. And, I just think it's so important for patients to start, demanding and expecting better of our healthcare system. And that is what potentially could really move the needle the rest of the way. Do you guys agree with that?
Absolutely. I think that one of the changes that we should be pursuing is this idea that it's not a demand. We don't want to have this us and them thing going on. Healthcare providers are terrified of liability. They're terrified of their malpractice insurance going through the roof. Healthcare consumers just want to feel better. They want to get better. They want to know that they're in good hands, and that they're safe. We need to rework that model on the patient side to help people understand that they really need to be an active participant in their healthcare and make it a collaborative process rather than I'm sick, I'm here, fix me.
Yeah, I agree. I mean, this is an interesting time that we're in. We've learned a lot about how our country reacts to healthcare. And before COVID, I'm sorry, this is going to be negative. I had a lot more faith in our ability to create health literacy across the board in this country if we just have leadership that takes it seriously. I was surprised by how individualized people's experience with healthcare literacy really is, and how sort of interpretive it became. I didn't see healthcare as that interpretive before. It felt like this is the thing that the professionals say, and that's the thing that it is. And, you know, and many times in our healthcare experience, that can be a problem where you just assume that a doctor is a doctor because they know everything and they're right all the time, or a nurse or a surgeon. And so we don't question anything. Questioning during the process is healthy if you're questioning to get clarity, if you're questioning to make sure that you're hearing the right thing. If you're going to get an antibiotic, you want to make sure you know what it is. If you have allergies, something like that. But to question the idea that harm exists is something that we're still fighting in patient safety itself. You can't actually solve anything until everybody's on board with the fact that it exists. And patients are going to be the best way to articulate that. Storytelling is what I do, and I think everybody has a penchant for it, and we need to teach people to understand how to tell their story so that people who deliver the care can learn from it, can learn from these experiences.
Yes.
People shouldn't just go to the hospital, get their experience, go home, be healthier or sicker, and then just say, well, it is what it is. Keep it to myself. I don't want to upset any of these doctors or nurses or hospitals. I am sure whatever they did was right.
Well, I think that's so well said, and I think it's easy for us in the medical profession to ignore numbers and statistics, but it's a lot harder to ignore things that come directly from our patients and the stories that they tell and the experiences that they have. So, Linda, you alluded previously to a study from the Patient Safety Movement Foundation. I'm going to read a couple of statistics from that study. They found that whereas 79% of public respondents thought that the word safe described a typical healthcare experience, just 42% of healthcare professionals did. The report also found that 72% of public respondents thought patients first described a typical healthcare experience, but only 36% of healthcare professionals agreed. 80% of health professionals believe that at least 75% of medical errors can be prevented. So we healthcare professionals know that these mistakes are not inevitable or unavoidable. What do these statistics say to you, starting with you, Linda?
Oh, they tell me that there is a systemic problem and that there is a very important disconnect between what people in healthcare know and what healthcare consumers see. And that ties to a point that Mike made a minute ago, which is that healthcare consumers who have a what I call a misadventure of one kind or another tend to think of it as an isolated incident. Though the provider was having a bad day, I should have done X, Y, or Z. Most people don't realize that these are not isolated incidents, that this is a systemic problem. And that, I think, is where we need to start the conversation on the consumer side. At the same time, we don't want to terrify people so that they're not getting health care. It's a very complicated balancing act.
So if I'm a patient listening to all of this, I'm worried now, and I am worried that the healthcare system is not a safe place. But one thing I like to do is give people tangible steps that they can take to try to address the problem. And I really do think this is one of those areas where if you engage and you make an effort, there are ways that you can keep yourself safe by being an engaged and empowered consumer. So the organization called Campaign Zero Families for Patient Safety has actually developed a checklist to help patients protect themselves from medical errors. Linda, is this something you could tell us a little bit about? And maybe you have some experience working with clients directly utilizing this checklist?
The checklist idea is one that actually comes directly out of Sullenberger's experience. And Atul Gawande has also written about it. It's a device. It's a support and a way of synthesizing information so that people who aren't familiar with healthcare protocols and language and all that sort of thing just have an idea of what to keep in mind when they go in to a facility. Campaign Zero was started by a woman named Karen Curtis, based again on her experience with a loved one who died as a result of a medical error. And she put together actually a library of checklists, one that deals with in hospital safety and the other one that deals with surgical safety. And she focused on what are called the never events, which are the leading preventable causes of harm. So it covers things, or the checklists cover things like sepsis and MRSA, bed sores, urinary tract infections. And it's a very plain language way of saying, okay, your loved one is in the hospital. They have a catheter. What are this is a high risk situation for infection. What are some of the things you can do to reduce the likelihood that there will be harm? And it's things like ask the question, when will the catheter come out? Do we still need to have this in place? It also starts with really basic things like, have you washed your hands? Have you cleaned? If the provider comes in with an electronic device, have you cleaned that? Another thing that I push very hard that anybody can do is the idea of managing your own information. And this goes right to the Sue Sheridan story in Mike's movie. Get hold of your test results. People think they can't understand them. They may not understand the details, but they can tell whether it's their name on the test report. They can look to see if it's the test that they had expected. If you're a man and under ordinary circumstances you get a mammogram report, something's out of whack. It is simply knowing your own medical history. I had started getting mammograms when I was in my 40s, and they identified what are called calcifications, little hard spots in the tissue. And those are usually very consistent. They get there, they stay there, they don't harm anything, but they don't go away. One year, I went to a new facility, had the test, got the report, looked at it, and said, we found, congratulations, we found no abnormalities, blah, 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 or calcifications. Well, did they send me the wrong letter? Have they magically disappeared? What happened there? Because there was a disconnect between what I knew and what I was seeing reported from the providers. So number one in my book is information management. Get hold of the documentation. Don't assume that everybody in your treatment team has that information. Be prepared to carry that information in paper form is my favorite. Although with COVID there are other issues. And be prepared to take that and say, have you seen this test result? Do you know this information? And be prepared to do that at every transition in care, right down to the shift change in staff, because the information, and I think this is the biggest issue in healthcare safety, information gets lost.
Yeah, so I think that's really well said. I, as a doctor, so appreciate it when patients are ask me questions or engaged or follow up on test results. And I'll even say that sometimes patients will say, why is my family member, why is that tube still in their nose, or why is that catheter still in there? And it's just a very elegant way of saying it. Why is it there, doctor? And sometimes I'll scratch my head and I say, you know what, there's not a good reason, and let's take it out. It doesn't need to be a confrontational thing. It can just be a simple intention to learn question. The other thing I love about the Campaign Zero Families work is the checklist idea, because there's so many things to remember, and unless there's an organized way of putting it together, you're going to forget something. And a checklist just it lets you go from 1 to 10 and make sure you check off everything on that list that potentially could go wrong.
There is a website, of course. It's campaignzero.org. And the checklists are free. You can download them and take them with you.
What policy changes are needed to advance the patient safety movement?
Well, it's a good question, and there's kind of two different areas of it. One that feeds right off of what Linda was saying is that we need to make sure on the local level at each hospital and each healthcare organization, there's an expectation that patients will engage, that this is an interactive experience for patients, not be quiet and wait for us to do our thing. Yeah. And I think in some of the places we visited making the film, we saw actual checklists provided by the hospital. Imagine a world where people didn't have to bring all their own stuff.
Yes.
So that would be a great first step internally for administrations and leadership in hospital setting to make sure that patients understand that their voices are being heard and they want to hear them by giving them the things to ask. Because right now, we're conditioned not to ask the questions that Linda expressed. On the national scale, though, I mean, look, AHRQ, they just need more money. And that's not going to solve every problem. But the reality is that they get, I forget the numbers now, but it's in the movie. They get literally a fraction of national healthcare spending, and yet they are the only agency responsible for making sure that the quality is good, right? So where are our priorities right now? It's all about access to care. Well, if we don't prioritize the quality of that care, what good is the access? Right? And when we give people free healthcare, what's the cost on the back end to them if that healthcare is not quality?
Poor quality care, bad care is inefficient care. And if you can make care more efficient, it also would help on the access side. So I actually see them tying in very closely. And I think you're absolutely right that we do need to shift some of our emphasis. I'm a big fan of NIH funding and developing new and innovative technologies, but we also need to figure out how to use existing technologies correctly and safely. And that's what Agency for Healthcare Research and Quality, or AHRQ, is all about. Well, this has been a really insightful discussion. I do have one final question for each of you. What advice would you give to my listeners as healthcare consumers, the next time that they have an interaction with the healthcare system? Why don't we start with you, Linda?
Oh, my. I've got a 5-step synopsis of, managing the information, managing your healthcare encounters, being prepared, not expecting anyone to know who you are, why you're there, or what the plan is.
And how about you, Mike?
Those are all very reflective of what I would say. And there is an opportunity to learn more about healthcare than just insurance. And I think a lot of people, it stops there. And we need to find a way to educate our children, not just ourselves. The whole airline thing about putting the mask on your children before yourself applies to healthcare and patient safety too, because at some point you're going to be the one that needs help and somebody to be there for you. And everybody in your circle should know what's going on and what to look for, not just, in your own healthcare experience, but when you go to the hospital.
Yeah. Well, I want to thank you again for joining me today. Again, Linda Beck, who's the founder of Square One Elder and Health Advocacy. You can check out her website. And Mike Eisenberg, who is the producer and director of the film To Err is Human, which can be found on Amazon and elsewhere. Thanks for listening to the Healthy Skeptic MD podcast. Please search and subscribe wherever you listen to podcasts, and join us next week. Thank you.